So my name is Basnyat. I am a clinician and a clinical researcher. The Birat Nepal Medical Trust, Birat, also sometimes Britain, Nepal Medical Trust, has been involved with tuberculosis control in Nepal for over half a century. And this talk is largely based on BNMT's work. So the title of my talk today is, how can we control tuberculosis, that is TB, in Nepal and beyond? And the answer is by treating latent, which means dormant, TB infection, or TB preventive therapy, TPT. Tuberculosis is the biggest infectious disease killer in the world. And many doctors also do not know this. But because it is a poor man's disease, it receives minimal attention and hence funding for the relentless killer it is. Just look at this. Between 2000 and 2015, 33 million people died of tuberculosis. I mean, isn't this a staggering number? That's more than the population of Nepal in that 15 years died of tuberculosis. And it's projected that 28 million people more will die of tuberculosis between 2015 and 2030. So these are staggering numbers. What about if we focus on Nepal? There are more than 69,000 cases of tuberculosis every year in Nepal. And over 7,000, 5 to 7,000 deaths. Over 5 to 7,000 deaths. What about each day? 190 cases of tuberculosis each day. And over 20, it's almost like 40 deaths per day in Nepal. Now here's 9 million people in Nepal are latently infected with the tuberculosis bacteria. This is a bacterial disease. So let me try to explain what this latent or dormant TB is, all right? So the patient is infected with tuberculosis bacteria, but does not manifest the full-blown disease. The patient has the TB bacteria, but the full disease hasn't happened. About 10% of people with latent or dormant tuberculosis will show the full-blown disease in their lifetime. So if we have 9 million people, as the previous slide showed, with latent TB in Nepal, just under 1 million will progress to full-blown disease. Excuse me. And this will perpetuate the cycle. And this is what's going on. We need to break that cycle. So full-blown TB is preventable. TB preventive therapy, TPT, again, that is treatment of latent TB, can reduce TB incidence in contacts of TB cases by 90%. So that's an impressive percentage. No effective TB vaccine exists. The TPT could work like a vaccine now. In the past, TPT was long. You had to take this for 6 to 9 months and difficult to complete. So TPT was not widely used. But now, there is a very short TPT, TB preventive treatment, just 12 doses. That is, once a week for 3 months for a total cost of $10. So the patient takes a fixed dose combination once a week for 3 months, 12 dosages. All the cost is just $10. And Indian companies like Lupin and McLeod make them. So this is not something that has to be brought from far away in the Western world. TB, it is safe and effective. So it's safe, effective. So now is the time to scale up TB preventive therapy to end the TB. It's an epidemic. We cannot afford to wait for a vaccine, while millions more die of a curable, preventable disease. And the WHO, the World Health Organization, completely endorses this, recommends this, as this statement shows. But unfortunately, they have no funding. So let me walk you through this diagram here, and exactly what I mean is illustrated here in this diagram. So we have adult household contact. All right, so someone has tuberculosis, is diagnosed in the hospital. It's very important to go to that patient's family. That's the household contact. That's called active case finding, ACF. Active case finding and preventable TPT have to go hand in hand. This is not happening. For some reason, WHO and others just focused on what is called DOTS. Just treat the patient, and that's what we need. What was the whole goal? But active case finding was neglected, and so was TB preventive therapy for many years. This has changed now, but this was probably an oversight. So we have to go to the patient's household, the household contact, check for TB symptoms. This is a standard questionnaire, all right? And if they have symptoms, yes, they go to the TB, they go to a hospital. They have no symptoms, but they live with the index patient with TB. They need what is called a TST, a TB skin test. This is done very commonly, all right? So it's also called the Mantoux test. And if they're negative, that's fine. Nothing else to do here. So this is the household contact. They're positive. It's a skin test that is read after 48 to 72 hours. I will show some pictures about this. Then you need to do a chest x-ray, very commonly done in a hospital. The chest x-ray is abnormal. There again, they have to be worked up for tuberculosis. But if the x-ray is normal, they have a positive skin test, then they are offered this TPT, which is also called 3HP. It's a drug combination. That's it. This is the algorithm. And here, the BNMT has done pilot studies in Chitwan, Bhutan, districts of Nepal. This is an example here where the health worker has gone to the TB patient's house and is explaining things. Do you have a cough? Do you have fever? And then followed that algorithm, that diagram I showed you. And they're given this, those that qualify are given that skin test I mentioned, the Mantoux test. And the test is read after 48, 72 hours. And if they're positive, more than 10 millimeters, this is again, as I said, it is done very commonly. This is not something new, has been going on for decades. Then they're given this medicine. So this is the new part. So every week at the health post, they're given this TB preventive therapy, TPT, for 3 months. A total of 12 dosages for $10. And this, as I mentioned, the BNMT has been doing pilot studies in Chittagong and Bhutan with excellent results. This needs to be done in all of our districts. It is what in medical terms we say is cost effective, you know? For every $1 invested in TB care and prevention, the return on investment is $40. So this is an important take-home message. In brief then, these are the stark facts. Let me just repeat these. Over 10 million people suffer from TB every year. 1.5 million will die. That is, 4,000 patients die daily. And mostly where? In TB hubs like Nepal, India, Pakistan, Bangladesh. Over 30% of patients with TB are never diagnosed. Patients sick with TB can infect, as I mentioned earlier, up to 10 to 15 other people per year. And as I also mentioned earlier, there is a 10% lifetime risk of these infected people developing the full-blown TB disease. That's the whole thing we're trying to do, to halt the progression from the infection to the full-blown disease. TB preventive therapy is 90% effective in halting that progression. And importantly, to emphasize again, there is no vaccine that is effective, especially in adults. So my last slide, second last slide, is a build-up. All these other slides are a build-up to this last slide. So I told you all about these things. So what can be done? TPT, right? Active case finding, TPT have to go hand in hand. What can we do about this? We need to use what are called activists to get like well-known stars. HIV activists successfully use this method. Who did they use? HIV, AIDS. You know, who did these? Who were these activists for HIV? They were Hollywood stars, many of them, and this really sent the message widespread. HIV was successfully controlled in many parts of the world. My simple question is, why not TB? And the answer is also, you know, this there's not been enough activists for many reasons. One of them is that this tuberculosis is by and large a poor person's disease. So we need to increase awareness of national and international philanthropists about TB and TPT so that they get involved, that they share their funding in this game changer deal. Traditional funders like Bill Gates, the Wellcome Trust from Great Britain, are presently focused on an expensive, over $1 billion tuberculosis vaccine research and development, which will take many years to bear fruit if successful. In the meantime, in sharp contrast, the relatively inexpensive, effective, and safe TB preventive therapy is immediately available to save millions of lives. This is a paradox. And I will end there. After acknowledging the BNMT people, specifically, specifically Mr. Raghu Dital here, and the principal investigator from Liverpool who resides in Kathmandu, Nepal, Dr. Max Cause. Thank you very much for listening to me.